Clear cell hidradenocarcinoma is another one of those very, very rare skin appendage malignancies. Unfortunately, there's not an awful lot of information in the literature. I think there's about 100 cases have been documented with no really big series in them. So it's difficult to get hard data. But I think by and large, these tumors are best regarded as potentially high grade. Now, clinically, they're not very distinctive. The one on the right, which I got from Dr. Asati in the Indian Journal of Dermatology, it looks almost like a turban tumor. But anyway, they present as basically as nodules in the dermis and extending into subcutis, and they can be quite large as seen in this example. Now, the important thing is they may arise in a precursor benign hidradenoma, and when that happens, the diagnosis is quite easily. But unfortunately, that's not the common presentation, and so that they can sometimes be quite challenging to diagnose. Now, the ones that I've seen have arisen mostly on the head and extremities, but I think you can get them just about any old place. From analyzing what literature there is, they recur very, very frequently, and I think there's a pretty high mortality with systemic spread, initially to lymph nodes and then further afield, particularly the lungs and the bones. Now, histologically, clear cell hidradenocarcinoma, as I mentioned, sometimes you see a precursor lesion, and the image on the right is a really lovely case that Professor Alex Lazar from the MD Anderson Cancer Center shared with me many years ago. And on the right side, you can see clear cell hidradenoma, and on the left, you can see a very obvious carcinoma. And that's just a perfect example of carcinoma arising in a precursor lesion. Generally speaking, the tumor is composed of nodules and lobules of epithelium showing ductal and glandular differentiation and varying degrees of pleomorphism, ranging from mild all the way through to a diffuse, almost anaplastic variant, which may lose the ability to form glands, and it just presents as a diffuse infiltrating tumor, and that's a very difficult diagnosis to make. Some of them show considerable necrosis, giving you a comedo pattern, and rarely clear cell hidradenocarcinoma may show a spindle cell pattern, mucinous metaplasia, and squamous differentiation, in my experience, is quite common, and it can look bonoid, and so if you're not careful, you can call these tumors squamous cell carcinoma. But if you look carefully, as on the left side of Alex's picture, you can see a very nice gland with a well-developed cuticle and lumen. Now, it can be quite useful to do some immunohistochemistry, particularly EMA and CEA, to pick up ductal differentiation. And the clear cells are full of glycogen, so they're PAS positive. Clear cell hidradenocarcinoma is CK7 positive. So I'm going to show you quite a few cases just to give you an idea of the spectrum that you can anticipate in these tumors. And this is that case of Alex Lazar's. This is the low power view, which you can't make much of other than you can obviously see there's an epithelial tumor. But when we look at it at a slightly higher magnification, they're occupying most of the tumor is precursor hidradenocarcinoma, showing quite marked clear cell change. And then on the left and superior aspect, you can see the carcinoma. And there's a close-up view there. It really is a lovely example. And there is the clear cell hidradenoma, and there's the carcinoma with nuclear pleomorphism, prominent nucleoli, and there are two mitotic figures. And there's another view of the same area, and you can see that there's a tripolar mitosis in the middle, and what you can see is that you'd be very hard pushed on that type of histology to make a concrete diagnosis at all. I think you would end up calling this carcinoma NOS, and whether it was a primary or a metastasis would be up for investigation. There's that mitotic figure. But then fortunately, there were glandular lumina, and there you can see a nice one in the center of the section. So we do know that this is an adenocarcinoma. Now here's another one, and this is sort of the other end of the spectrum, where there's a very malignant tumor showing comedo-like necrosis, and there is certainly clear cell change. And there's a close-up view there showing the clear cells, a lot of apoptosis and conspicuous mitotic activity, but difficult to make a definitive diagnosis on that field. And there's a close-up view there showing some mitotic activity in the upper left quadrant. And in this field there are multiple mitoses. There are 4 in that. There's 5. 1, 2, there are 5, and you can see apoptosis in the upper left quadrant. And there's a field emphasizing the comedo necrosis. And there you are, as I mentioned, you can see squamous metaplasia, and it can be very pleomorphic, and so I think it would be quite easy to look at that and think, oh gosh, this is a squamous cell carcinoma. There's another view there. But fortunately, again, there were conspicuous glandular foci with glandular differentiation and intracytoplasmic lumina, and so we were able to make a diagnosis of clear cell hidradenocarcinoma. Now I can't be absolutely certain because this is a very old case, but I think we were helped in our diagnosis by a past history of a pre-existent tumor, but I can't swear to that. And then this is a lovely case that Carlos Ceruto from Florida shared with me. And here you can see clear cell hidradenoma associated with a lot of basement membrane deposition. And there's another view there. So that bit's clearly that bit looks like a clear cell hidradenoma. But then when you look closely, well, there's a hyperchromatic nucleus, although one nucleus doesn't really amount to much, but it's a start in causing a little bit of concern. And then elsewhere, we start to see quite marked nuclear pleomorphism with very conspicuous nucleoli. Look at those in the top right quadrant. They're huge nucleoli. So I think we can look at this and say, there's a carcinoma. So I think this is another example of carcinoma arising in a precursor lesion. And there's the tumor showing necrosis and a lot of inflammation. And there is a couple of more pleomorphic cells that just catch your eye. And another view. And another close-up view showing very prominent nucleoli. And there's a mitosis in the bottom left quadrant. And here again you see squamous differentiation. And as I mentioned, I think this is quite a common feature. It's just a distraction rather than meaning anything. And here we have a more obvious carcinomatous component, and much the same with extensive necrosis in the upper left quadrant. And here you can see a focal clear cell change, but the tumor is infiltrating in a very irregular pattern. So I think, it's pretty obviously a carcinoma. Again, showing some squamous differentiation in the bottom right quadrant. And there you see a high-grade element where there's very marked nuclear hyperchromatism and conspicuous mitoses, with a close-up view there showing 1, 2, 3, 4, at least 4 mitotic figures. So another clear cell carcinoma arising in a hidradenoma. There's a close-up view there, and another one there. And this, Carlos used EMA, which I think quite nicely outlines some intracytoplasmic lumina with a well-developed cuticle. Unfortunately, they can be hard to find, so you have to look really hard. There's another one there. There's probably another one in the bottom right-hand corner. So ductal differentiate or intracytoplasmic lumen formation with EMA. And this is the key 67 showing that it's very, very brisk. And then here, this is a really tricky case that Antonina Kalmakova from CSD Healthcare shared with me. And it's really quite difficult. This is a tumor from the sole of the foot, which you can tell by the very thick stratum corneum. And there's an exophytic ulcerated mass. And when we look at it, a close-up view, it looks awfully like a clear cell hidradenoma. There's not much in the way of pleomorphism. In fact, you'd be hard pushed to call that carcinoma. And then the only bit that was a little bit worrisome was in the top of the field adjacent areas of ulceration, and there are cells with large nuclei, prominent nucleoli, and that was the only area that I could find in this whole tumor that would have raised the spectrum, the specter of hidradenocarcinoma. But then, I don't quite know why, the surgeon did a sentinel node biopsy, and hey presto, there's metastatic clear cell carcinoma, which is, morphologically identical to the primary on the foot. But it does show glandular differentiation, quite conspicuous. So it's not difficult to recognize this as hidradenocarcinoma, but I suppose you could call this a well differentiated variant. Now, differential diagnosis, most times it's not, one has this list, clear cell porocarcinoma. Well, the only difference between a clear cell porocarcinoma and a hidradenocarcinoma is the porocarcinoma shows an origin from the overlying epidermis. So it's not difficult to make that distinction, provided the lesion isn't totally ulcerated. Clear cell squam, I think, is certainly an important differential, particularly as I've shown you the tumors most show squamous differentiation, and the diagnosis then rests upon identifying ductal and glandular differentiation. Trichilemmal carcinoma is one of those tumors that's almost as rare as hen's teeth, but again, it will not show ductal or glandular differentiation. Clear cell melanoma, well, this is a lovely clear cell melanoma that Antonina shared, and on the top is the H&E with abundant clear cells, and on the bottom is SOX10, so that makes the diagnosis fairly easy. Clear cell metastatic carcinoma is something that one occasionally has to worry about, and I'll show you a couple of examples later. And on the topic of differential, I just want to mention atypical hidradenoma. Those of you who know me know that I'm not very keen on the concept of atypical lesions. And this again applies to hidradenoma, hidradenocarcinoma. If you see an occasional hyperchromatic nucleus and nothing really elsewhere, then I suppose if you want to call it atypical, well, you can, but it doesn't really advance us in any meaningful way. I think when you see atypical cells, then you should be very cautious and start looking at lots more of the tumor and make sure you're not picking up conspicuous mitoses or atypical mitoses. So just be careful with the atypical hidradenoma. I think Antonina's case made that point very nicely, because it clearly is a carcinoma, and yet the atypical cells were only really present in one area. So there's an old case of mine from way back when of squamous cell carcinoma with clear cell change, and on the right is a PAS showing the presence of glycogen. And then this is a clear cell porocarcinoma. I used to have a couple of examples, but I lost them long ago. But you can see how similar clear cell porocarcinoma is to clear cell hidradenoma, even with the presence of squamous differentiation. On the left we see EMA, which is outlining some ductal structures, and on the right is CEA, which doesn't really help us one way or the other. And then this is a nice case of trichilemmal carcinoma that Wayne Grayson shared with me quite a few years ago. And this is it's exceptionally rare, but I think you can recognize it without great difficulty, because it always shows this conspicuous basement membrane. Sometimes this is very thickened around the edge of the lobules of epithelial cells, which are devoid of any attempt at glandular or ductal differentiation. And in the lower left quadrant shows you conspicuous mitosis, and on the right there's necrosis. So that's a nice example of trichilemmal carcinoma. And then metastases. Renal cell carcinoma, I suppose, is the one we always think of for clear cell metastatic disease. And it's usually instantly recognizable because of there's always massive hemorrhage. But if you are having any problems, then immunohistochemistry helps. Particularly CK7 is negative, and then there are a couple of markers that are more specific for renal cell tumors. And clear cell thyroid carcinoma that certainly could do very nicely for clear cell hidradenocarcinoma, but clear cell thyroid tumors are positive for thyroglobulin. And in any event, if there is a difficulty, I think you would get some decent clinical information and probably discover the diagnosis anyway. And then lastly, I just wanted to remind you that you can get clear cell carcinoma of the bronchus. So I hope this talk has been of some use to you. And if you have any questions about clear cell carcinoma, don't hesitate to ask me, and you can let me know whether you enjoyed the talk or not. So thank you very much for your time.